All right,
Hey, Rock.
ready to rock. Go ahead and introduce yourself to everyone who doesn't know you.
Good. So everybody, for those of you who I have not met, my name's Connor Fling. I'm one of the R3s in the program. I am now, I think, one of three Connors in the program with the addition of two new intern Connors, I think one of whom is represented on the call today. Today I was going to give a talk on substance use in critical care. It'll probably be a little bit of a change of gears from the past two talks, I would say. Here, as you can see, we have Harborview represented for a couple of different reasons. One, I have a lot of love in my heart for the Hospital of Harborview. So my clinic is. I'm going to do a chief resident year there next year, and then I think that Harborview is also a place where a lot of excellent substance use disorder treatment and also critical care take place. So I felt like it was an appropriate image to have represented on the title slide. A little bit of an outline for today's talk. Today, we are going to essentially go through some case presentations of common things that we take care of in the ICU setting that are substance use related. We will then review substance use disorder treatments more in the outpatient setting. We will have a little bit of a group think on health equity and what that means. And then finally, we'll tie it all together with a discussion on why substance use is a matter of equity and is health equity related. A couple learning objectives for today's talk. One will be to identify common substance use associated ICU presentations, things that we see quite a lot. Two will be to propose treatment options for various substance use disorders, again, in the outpatient setting. Three will be to define health equity using our own words. And finally, we will try to conceptualize how substance use and equity are intertwined. A couple things to not expect from this talk, a couple disclosures, I guess, if you will. While I'm interested in critical care, I'm not yet an intensivist, and so do not expect this to be a really deep dive on the workup and management of critical care pathologies. I think similarly, I'm interested in addiction medicine, but I'm not an addiction medicine doctor, so don't expect this to be an exhaustive discussion on outpatient treatment of substance use disorders. And then while I have a deep interest in health equity and part of the health equity pathway, I'm certainly not an expert. And so don't expect this to be a deep commentary on the landscape of health equity. Rather, I would say this is a tiny bit of each of those things that's blended in a fashion that is meaningful to me and hopefully somewhat practical to you. Okay, a couple of ground rules for the case presentations here. So the way the case presentations will work, hopefully there'll be some audience participation. I will present essentially a very brief patient presentation with pretty minimal data. I'm then hoping that there'll be some audience participation in which you guys will be able to, guess the diagnosis of what's going on. Then you'll hopefully be able to associate that diagnosis with a particular substance that could precipitate that presentation, and finally suggest a treatment. I know that there's a couple of pulmonary critical care bound R3s on the call. I know there's a couple of interns on the call who have done their NICU rotation, and I think Will Schiefling's on the call, who doesn't know much but usually contributes to the group chat. So hopefully we can all actually have some commentary here. With that, we'll get into the case presentations. So case one is a 68-year-old man who presents with shortness of breath and cough for 1 day duration. In the ED, his vitals look like this: a temperature of 36.5, heart rate of 126, blood pressure of 154/86, breathing 34 times a minute, and saturating 89% on 6 liters. On exam, this is a thin, older man who's moderately distressed, tachypnic with significantly increased work of breathing. Biphasic wheeze is appreciated diffusely with a prolonged expiratory phase. Does anybody care to guess what our diagnosis may be here? Oh, I kind of already hinted at it, so I'm not going to actually make you go through it, but this is a pretty common presentation of a COPD exacerbation. And this one's so easy that I'm not actually going to require you to guess the substance association. I think we all know what the substance association is here, but that would be tobacco. Does anybody want to go out on a limb and suggest what they might recommend for management of this patient? I'm not sure if I'm seeing the chat or not. I don't know if I am. If somebody can see the chat and people are putting it in, does somebody want to yell it out?
Nothing in the chat thus far, Connor, but Duaneb's cap coverage seems like P to F ratio is not severe enough to necessitate steroids, but those are kind of the key things that I would think about NRT while inpatient.
Sweet. Yeah. And, I think with this work of breathing, though, you could make an argument for how this patient may require some bilevel, ventilatory support. So I think all those things are quite reasonable, but good work. All right, let's go on to case number 2 here. So in case number 2, we've got a 42-year-old woman who's presenting with 1 week of progressive shortness of breath, fatigue, and leg swelling. In the ED, her vitals look like this: temperature 36.7, heart rate of 115, blood pressure of 80/68, breathing 28 times a minute and saturating 92% on 6 liters. On exam, this is a middle-aged woman who's tired of hearing, aroused the voice, tachypnic with coarse breath sounds that are diminished in the bilateral bases. She's got JVP to the earlobe at 60 degrees with difficult to appreciate radial pulses and 3+ edema to the mid-thigh with modeling of the bilateral knees. Anybody have any thoughts on what this might be? Yours is the only face that I see right now, and I know you're cardiology inclined, but I don't mean to put you on the spot.
Wait, were you saying my face?
Yeah, yours is the only face I see right now.
Oh, hi. Yeah. I think, well, I'm just going to read off the chart, the chat. Everybody's saying acute decompensated heart failure, which
I
I'd
love
agree
that.
with.
I love
Yeah.
that. Thank you. And Joe, would you mind actually being like a spokesperson for the chat? Is that putting you on the spot too much? Just because I don't
Say no
know.
more. I'll do it.
Appreciate you, bud. Yeah, I would say this is, kind of pericardiogenic shock secondary to decompensated heart failure. What substances can precipitate a decompensated heart failure perspective or kind of presentation?
We're seeing stimulants. Astrid also mentioned salt at Thanksgiving. Definitely alcohol as well.
Love all of those. Yep, I would say cocaine, meth, and alcohol. And I should clarify, there are substances like salt and all those things. I'm kind of talking more about recreational substances that have some degree of abuse potential. That's kind of the focus of our talk today. Okay, so we've kind of associated this decompensated heart failure with cocaine, meth, and alcohol. Anybody want to propose a treatment for what we might do for this patient who's in pericardiogenic shock? All right, we'll move on. Certain things you can consider inotropes, pressors versus afterload reduction, depending on which cardiologist you're working with. Potentially some positive pressure, diuresis, and plus minus on the mechanical circulatory support. So all things to consider. All right, moving on to the next case. In this case, we have a 42-year-old trans man who's presenting for evaluation of worsening chronic bilateral lower extremity wounds. In the ED, their vitals look like this: temperature of 36.5, heart rate of 140, blood pressure of 224/162, breathing 25 times a minute and saturating 92% on 2 liters nasal cannula. On exam, he's got a regular tachycardia, mildly increased work of breathing with diffuse crackles appreciated bilaterally, elevated JVP with 3+ edema to the knees with overlying chronic skin changes and numerous open ulcers, some draining purulent material. And then the bilateral upper extremities, you notice some kind of track marks there. This is his EKG, which won't necessarily make anybody read formally. If anybody has any overwhelming thoughts besides, ooh, scary, let me know what you think. Joe, you're smiling.
There's a comment in the chat that it comes from Lily, says make Joey read it.
Joey,
I'm
read
kind
it.
of joking.
Yeah, just
Okay.
listen.
Well, anyway, I'll get into it. Looks like the rate is fast, 150s or so. Looks like it's hard to tell. It looks like it is sinus from what I can appreciate approximately. But I'm not able to see a clear P wave in all of these. Axis is also looking appropriate. Looks like the QRS is up in 1, isoelectric and AVF, and then also looking for any sort of interval prolongations, changes, other things like that. QRS does look a little bit wide, especially in B1. Some kind of elements that could be consistent with the left bundle pattern. And then that makes it difficult to interpret ST wave changes, but I'll remark more on that later. QT also looks to be about like 1/2 of the RR interval, but who am I kidding if I can actually comment on that appropriately. And PR is also difficult to assess at this time. I don't have Scarboson criteria memorized off the top of my head, and otherwise it makes it a little bit difficult to identify ST wave changes because there are some J point elevations and changes. So those are kind of the initial things that I'm taking away from this. I'm not seeing frank evidence of right axis deviation or right heart strain that I would also be worried about in somebody coming in with tachycardia. But those are my initial thoughts. Anything else to add?
That's amazing. I agree with all of those thoughts. I think my kind of takeaways here are flattened PR, maybe absent PR, wide QRS, potentially peaked T waves. Does that constellation of symptoms or findings tip anybody in any direction about what this might be? This is a patient that I took care of my intern year in the MICU, and their potassium came back at 8.5. So the constellation of, I guess, volume overload, hyperkalemia, this is something I would consider to probably be likely dialysis dependent CKD5. That's another term for ESRD. Andy Lux has pioneered that term a little bit. And, you know, given the suggestions of potentially some injection drug use on the upper extremities, anybody have any thoughts about what may have precipitated this presentation? I know Lily's on the call. She's going into nephrology. Like, you want to comment? I'm calling people out now. Maybe Lily's not here. So this is kind of a classic presentation for AA amyloid kidney associated with black tar heroin injection. I think a lot of the studies that actually were done in this realm were done out of Seattle in our hospital systems. But, you know, the impurities in the black tar heroin cause some kind of chronic inflammatory response. The liver upregulates serum amyloid A protein, and that gets lodged in the kidney. And unfortunately, we have a pretty sizable population of patients in the Pacific Northwest who have essentially dialysis-dependent CKD5 from AA amyloid from injection drug use. We spent a lot of time on this case, so we won't go deeply into it, but, you know, management for this patient would probably be some degree of temporizing for their potassium, and then ultimately they will need emergent HD at the end of the day. So they're going to the ICU.
Lily mentions that this is Northwest specific, and also that she is here, probably won't see it as much in other places.
Sorry, that is not, or is Northwest specific?
Is Northwest specific, sorry.
Yeah. Okay, sorry to call you out, Lily. Case 4. We've got a 55-year-old man who's brought in by family for progressive confusion and vomiting. In the ED, his vitals look like this: temperature 37.1, heart rate of 122, blood pressure of 80/55, breathing 8 times a minute, and saturated 95% on room air. On exam, this man is lethargic. He's borderline obtunded. He's got icteric sclera with diffuse jaundice. He's got dark brown and black emesis kind of coating his teeth and lips, the regular tachycardia, and a distended abdomen with a fluid wave. Anybody have any thoughts about what this might be?
People are mentioning cirrhosis, decompensation, hematemesis, maybe some variceal bleed.
Yeah, like all those things. So decompensated cirrhosis, probably some hepatic encephalopathy, and then everybody suggested GI bleed with concern for variceal hemorrhage. I'm not even going to ask the substance association. We know what that is. What do we want to do for this patient? Why is this patient maybe going to the ICU? I would say with their level of, you know, maybe,
Yeah.
Oh, sorry, go ahead, Jay.
I was just seeing like needing pressors, possible FEP, GI probably needs to get involved.
Yep, I like all of those. I think don't forget about, you know, your patients with very decompensated cirrhosis and concern for hematemesis, whether they're protecting their airway. This guy may or may not be protecting his airway, but I like all those things. GI bleed kind of cocktail, especially with concern for this being a variceal hemorrhage, and then talking to GI and probably numerous other things in his management as well. All right, next case. We've got a 35-year-old gender non-binary individual presenting with subacute progressive shortness of breath. In the ED, their vitals look like this: temperature 36.2, heart rate of 115, blood pressure 92/54, breathing 32 times a minute, and saturating 91% on 4 liters nasal cannula. On exam, they're a thin individual in mild distress with fairly poor dentition. They're tachypnic with clear lung fields, irregular tachycardia with prominent S2 and JVP to the angle of the mandible at 90 degrees with a prominent V wave. And they've got 2+ edema to the mid tibia bilaterally. This one's a little trickier. Anybody have any thoughts about what this might be?
There's a mention of pulmonary hypertension.
Nice. Clear lung fields, volume overload. I think that sounds like pretty bad decompensated right heart failure. I agree. What substance would you say is commonly associated with pulmonary hypertension?
Overwhelmingly methamphetamine.
Yeah, there seems to be a predilection on the West Coast for this this kind of meth-associated, toxin-associated pulmonary arterial hypertension. This is a group 1 pulmonary hypertension physiology. So important to keep on your differential. What are we going to do for this patient?
Careful diuresis is being mentioned.
Yeah.
People with meth use consider like contingency management, but we don't really have that many programs here. Also consider like ambrisentan and tadalafil.
Nice. I like all those things. I like the mention of contingency management. That's something we'll get into a little bit later. But yeah, I would say, diuresis, they may need pressor supported diuresis to kind of support their blood pressures as they're getting diuresed. And then, down the line, pulmonary vasodilators like sildenafil, tadalafil, macitentan, those kind of things. And all right, last.
Can I just ask? I don't know if you're going to get to this later, but for all of these cases, like we have therapies for some of them that work better than others to prevent future use. Are there ICU studies that are coming out with kind of when to time those medications, or is that not really something that we're seeing at this point in time?
Are you saying like kind of maintenance therapies for their underlying substance use disorder, or are you saying?
Exactly, yeah, like alcohol use disorder, thinking of like naltrexone. Is that something that we're starting in the ICU, or should we really defer to once they get to the acute care or even to the outpatient setting?
Great question. That's not necessarily going to be a complete and utter focus of our conversations. I think probably for any, I guess my personal practice and recommendation would be that any patient who's presenting with such severe substance use associated issues that they end up in the ICU, I think that person automatically in some ways warrants a addiction medicine consultation if they're open to it. And then, with your addiction medicine colleagues, you can talk about the safety and whatnot of kind of initiating maintenance therapies to prevent this from happening again. I think in my personal experience, depending on the substance that's being utilized, when those maintenance therapies are initiated may vary, and it might not be during the kind of like sentinel hospitalization, and it might be outpatient follow-up that those therapies are started. But we'll kind of get more into the substance use disorder treatments and maintenance therapies in the next section. Does that answer your question, Will? Kind of give a shoulder shrug there, half-heartedly. All right, well, I did my best. All right, case 6. I'd be shocked if anybody has seen this before. Just kidding. This is unfortunately all too common. So in case 6, we have an unknown age man brought in by EMS after found down, surrounded by a lighter and foil, 6 rounds of CPR in the field with 2 milligrams of epi, no shocks before ROSC. In the ED, their vitals look like this: temperature of 31.2, heart rate of 102, blood pressure of 82/56 on 0.26 of norepi and 0.04 of vaso. They're saturating 96% on volume control 600, 12, 21, and 5. On exam, they're intubated. They've got 4 millimeters and sluggishly reactive pupils with no cough, no cough, no gag, no corneals. They're not overbreathing the vent and do not withdraw to knock the stimuli at any extremity. Anybody want to guess what this is?
hypoxia respiratory failure leading to cardiac arrest in the setting of possible fentanyl use.
Yeah, I agree. You know, this is unfortunately something we see all too commonly, especially in our review, ICU, cardiac arrest from likely opioid toxicity. I think we already talked about the substance that usually precipitates this. There's opioids of all kinds, but I think with the advent of recreational fentanyl, the blues that you know, are existing in alarming volumes on the streets, this has become all the more common. I think the other thing to consider here, though, is that, you know, not everybody who presents with cardiac arrest or opioid toxicity had an intention of using an opioid. I think that just speaks to the tendency for fentanyl to have found its way into essentially all street drugs that are out there. We'll talk a little bit more about this, but, you know, people who are primarily using methamphetamines or cocaine have no interest in using an opioid. Unfortunately, sometimes get a toxic dose of fentanyl, so that's something we should consider. We won't go too deep into the management here, but, you know, this patient's going to get admitted for targeted temperature management or targeted normothermia. They're going to do the whole neuroprognostication thing and some supportive care for their post-arrest shock. All right, so I think the take-home point from these cases here is the following, that I hope I've convinced you in some ways, or maybe you already knew, that substance use contributes to many of the common presentations that we see in the ICU setting and really deserves special attention before it manifests as life-threatening illness. And I think the other thing that I will say is that I think as residents in our program, we have the unique opportunity to be both ICU doctors, where we see how severe things can get and take care of people during their critical illness. But we also have our primary care clinics, and we take care of many of the same patients in the outpatient setting. And so I think we are uniquely served to kind of identify that this is a really big issue, because we can see how severely it manifests, and we can still kind of try to influence change in our primary care setting. Any questions, thoughts about the cases before we move on to treatment of substance use disorders in the outpatient setting? All right, we'll get into it. So this will be a kind of, again, a brief overview and review of the management of various substance use disorders. So we'll talk about alcohol, we'll talk about tobacco use disorder, opioid use disorder, and ultimately stimulant use disorder as well. Starting with alcohol use disorder, I think about alcohol use disorder kind of falling into two categories. There's kind of psychosocial interventions, and then there's pharmacologic interventions. It seems like pretty much everybody who has success with alcohol, abstinence from alcohol, in the long run has, you know, some sort of psychosocial intervention, and that could be a 12-step program like AA. There are, you know, it's just important to know that there are more intensive outpatient therapies and treatment programs. And then there's also inpatient programs for management of severe alcohol use disorder. And so just know that there's kind of gradations of how, you know, what you can recommend based on the severity of somebody's alcohol use disorder. From a pharmacologic standpoint, this, I think Will was referring to this earlier about, you know, when to initiate medications for alcohol use disorder. It seems like the most popular kind of pharmacologic management of alcohol use disorder at this point is naltrexone, and the long-acting injectable form of naltrexone is Vivitrol, and so that can be a pretty effective treatment for a lot of people. This seems to be first line, but you should note that, you know, using this in somebody with concurrent opioid use can precipitate withdrawal, and so you can have a bad effect. So certainly screen for opioid use when you're thinking about initiating this therapy. Other agents that can be effective in alcohol use disorder include acamprosate, which some people use if there's kind of a contraindication to naltrexone. I think we're seeing an increasing prevalence of the use of gabapentin, especially in patients who have chronic comorbid pain conditions. And then, you know, I think disulfiram still exists, but it seems to be falling out of favor a little bit. But know that that is still an option for patients who really wish to have that. From a tobacco use disorder standpoint, I think of tobacco use disorder and this is probably a review for everybody, but I think of tobacco use disorder in two broad categories. I think about nicotine replacement therapies, and I think about adjunctive therapies, and oftentimes these are used in conjunction. Again, I'm sure I'm just preaching to the choir here, but just as a review for anybody, for nicotine replacement, I encourage you to think about your nicotine replacement kind of the same way you'd think about like your insulin management, in that you have a basal coverage with something like a patch that kind of provides a basal level of nicotine replacement, and then a bolus coverage with something like a gum or a lozenge that can kind of curb an acute craving when somebody has one. And then in terms of adjunctive therapies, the main data actually really supports Chantix varenicline as being like first line. That seems to be the preferred. It has the most data to support it, but bupropion is also an option if Chantix varenicline has not worked, or somebody's got some comorbid depression or something else that might benefit from bupropion. In terms of opioid use disorder, this is a big one. I think we all should be well versed in this. I think well, let's see, how did I organize this? Yeah, I organized this in the form of the first thing to think about is harm reduction strategies. So this can involve things like never using alone, or having your patients have Narcan, and then things like needle exchanges to reduce the risk of transmissible illnesses and diseases. I would say one of like the most humbling things in my short career as a physician so far has been trying to counsel my patients on some of these harm reduction strategies, and ensuring that my patients who are using opioids have Narcan at home and that they know how to use it. And if you speak to somebody who's been using opioids for a long time, it's really amazing like how many of these people have saved countless lives because they have Narcan, they've used it so frequently. And it's, I think that the response I've gotten sometimes is like, I ask, do you know how to use your Narcan? And people are like, do you know how to use Narcan? And I think that's so interesting because like, yeah, I've given IV Narcan in the hospital, but personally, I've never saved anybody's life with intranasal Narcan. So anytime you hear about that from a patient, I think just commending them on the awesome work they're doing is really important. And then getting into actual, pharmacologic therapies for opioid use disorder. Obviously, this kind of falls down into two main categories at this point. There's methadone, and then there's buprenorphine-based therapies. I will say that from the methadone perspective, for residents, I think the important things to know are the resources that we have in our area for how to get people plugged into methadone. And that really falls into three big agencies in the community that are doing methadone work. There's Therapeutic Health Services, that's THS. There's ETS, which is Evergreen Treatment Services. And the kind of new kid on the block is We Care, which is like a more mobile van that outreaches people in the community. Super cool work that they're doing. So I think just knowing about those different resources so that we can get people plugged in after they leave the hospital is amazing. The other thing that I recently learned, and maybe a lot of you already know this, but this was new to me, is that there's this kind of new, I don't know if it's like a policy or a law or what it is, but there's essentially this new thing where as inpatient doctors, we can prescribe, I think, up to 3 days of methadone for our patients to take home with them. And that's really important for a patient who comes in for some other issue, and then we get them started on methadone, and we get them scheduled for a methadone intake in a couple of days, but their kind of indication for acute care hospitalization has otherwise concluded. It's just important to know that we can send them home with the tools for success, and it's kind of a fun process because you actually have to like go down to pharmacy, pick up the medication yourself, and like hand deliver it. It's kind of a process, but I think it's really important to know that exists. And then just very briefly talking about the buprenorphine-based therapies, obviously this seems to be, it seems like an increasing number of people are using buprenorphine-based therapies, which I think is awesome. I think the first was buprenorphine monotherapy, that's also known as Subutex. There was still some degree of abuse potential if you injected that because it didn't include naloxone, and so that's largely been supplanted by Suboxone, which is a combination therapy with buprenorphine and naloxone. And then I think the third option, which probably most people know about, but maybe not everybody, is Sublocade, which is a really cool long-acting injectable form of Suboxone, which can be great for people who struggle a little bit with taking their medications, and kind of having a set it and forget it one time a month injection is really helpful. All right. And then moving last into stimulant use disorder.
Connor, there's a question someone asked about. How do you decide between starting someone on methadone versus Suboxone?
Yeah, I think that's a pretty nuanced conversation. I think ultimately it comes down to patient preference in a large way. I think that as clinicians, we can try to help suss out whether somebody may benefit from, having the regularity and scheduled aspect of going to a methadone, treatment facility every day and having that kind of structure in their life. I think that for the vast majority of people, that's like slightly less optimal, to kind of be going down to the methadone treatment facility every day. And so I think the general tendency is like Suboxone is preferable for most people, but again, I think that's an individualized conversation. And I think a lot of people who are existing in this space who have lived with opioid use disorder for a while have probably tried one of these therapies and maybe had not such great effects. And so, you may be that may also guide your conversation as well. I'm not sure if anybody else has other practices or thoughts on how they triage that.
I think to add to that as well, it really depends on people's use patterns as well. If they're using like a roll of fentanyl a day, meaning like, I don't know, just a really significant amount, buprenorphine alone might not be able to manage their subsequent cravings, other things like that. People in the chat, Joanna is mentioning QTC being a limitation to starting methadone. Great thought there as well. And then I think one thing that isn't really talked about as much as like kind of side effects of methadone itself. People can experience significant hypogonadism and other complications, and weaning from methadone is significantly challenging. So I think really just exploring those goals with your patients a little bit more is always going to be something that's important.
I love it. I love this collective mind we got going here. This is perfect. Any other questions that have come through the chat that I've been blazing through? Looking at you.
I think most of them have been answered. Yep.
Right. All right. And finally, we'll cover stimulant use disorder. And so stimulant use disorder, similar to alcohol use disorder, I think I break down into two categories of intervention. There's a psychosocial intervention and there's pharmacologic intervention. Somebody had mentioned earlier that a lot of, somebody had mentioned contingency management in the chat earlier. I don't remember who that was. But I think that highlights, that a lot of the data in this realm actually does kind of focus more on the psychosocial interventions. And unfortunately, we are slightly limited in our kind of pharmacologic interventions for stimulant use disorder. So psychosocial interventions can be things as simple as individual or drug group counseling, intensive outpatient therapy, but then also a lot of data to support the use of contingency management, which, if you're not familiar with contingency management, it's kind of interesting. It's like a incentive-based program where anytime the patient turns in a UA that doesn't, or not a UA, but a UTOX that doesn't have the substance of interest, meth or cocaine in it, then they get some sort of incentive, usually financial, I think. And so that kind of taps into that whole reward pathway of the brain that I think is also tapped into with stimulant use. And so kind of a creative way to subvert ongoing substance use in that way. In terms of pharmacologic management, unfortunately, we're a little bit limited. I'll break it down into cocaine versus meth. But for cocaine, there is some data to suggest that topiramate can be beneficial. I don't see that utilized too often, quite honestly. And then there's also some data to support long-acting amphetamines, kind of in a way like we use methadone for opioid use disorder. If we're using a longer-acting amphetamine, it kind of may help for cocaine use disorder. But again, the data here is slightly limited. For meth, there's also some limitations, but the best data is really around bupropion and naltrexone use. I have not seen that used too much in at least my own primary care patients who have methamphetamine use disorder, but something to consider. And then there's also some data to support mirtazapine use as well. I think the data is more limited in that realm compared to bupropion and naltrexone. I think this is another use disorder category that I would really strongly advocate for harm reduction strategies. Kind of like we talked about in the case 6 there with the opioid overdose. I think a lot of the substances that are floating around in the street these days, unfortunately, are contaminated with fentanyl. And so Narcan for everybody, never using alone. And this population in particular, again, there's a lot of people who are out there using meth or cocaine who have really no interest in using any sort of opioid and are pretty appalled by the amount of fentanyl that is permeated into the supply of their drugs. And so they're actually highly motivated to use fentanyl test strips to see if there's, some suggestion of fentanyl in their supply. It's not a perfect strategy. You might test one little piece of fentanyl or one little piece of your drug that doesn't have fentanyl and the rest of it might have some. So it's not perfect, but I think it's better than nothing. And then the last thing I'll say is that there's some people in our system doing cool work to kind of pioneer the use of harm reduction naltrexone for people who are primarily using stimulants, but want like a little bit of backup for preventing opioid toxicity if they unintentionally ingest fentanyl. And this is actually different than what I was referring to with the bupropion and naltrexone, which is aimed at actually targeting the meth use disorder. This is more just like harm reduction to prevent opioid toxicity. I think that wraps it up in terms of things that I wanted to talk about for outpatient management of substance use disorders. Does anybody have any questions or anything that came through? Nothing. All right, so I think we've probably got like 8 minutes, maybe. We'll try to speed through this, but you're probably wondering why, we're talking about critical care and substance use on the academic half day for health equity. So now I kind of wanted to switch gears and finish up on health equity related matters and talk a little bit about how we as a group define health equity. And I'll preface this by saying that I feel that the term health equity has kind of gained a lot of popularity in the medical field in recent years and has kind of become somewhat of a buzzword. And from my own personal experience over the past 5 years, I've become increasingly attracted to the concept of health equity and interested in how I can incorporate that into my medical practice. Though admittedly, I'm not sure that I've really fully thought out what that means for me until fairly recently and thought about how I personally define health equity. And I suspect that I'm probably not the only one that feels that way. So I wanted to kind of do just a brief exercise where we take a little bit of time to think independently for maybe 2 to 3 minutes about how we each would define health equity and see if we can come back together to kind of share some thoughts, because I'm curious to hear how other people might define this space. So I'm going to give you 2 minutes to think about this, and then hopefully somebody feels comfortable enough to share their thoughts about what health equity means to them. I'll give it 15, 20 more seconds. Does anybody feel, I'm going to share my definition here on the next slide. But does anybody feel comfortable either unmuting or using Joy as their voice box?
There is a comment from Eamon mentioning that it's really something that's still evolving, but looking at the many aspects of an individual beyond their disease that impact care in both positive and negative ways.
Yeah, I like that, and kind of approaching people in a more holistic way and taking into account their social context in which they live, and everything is super important. Any other thoughts from the crew?
I put this.
Amelia's, oh, yeah, go ahead.
Oh, sorry. I'll just say it out loud. So, yeah, thanks, Connor. I think like you and Eamon, I'm still thinking a lot about this also. And I think part of my definition would include just how systems of oppression and power influence a person's health and their care also.
I love that. The health equity pathway residents are really representing. That's why I love you guys. Cool. Well, I think we've got only a couple minutes, so we'll breeze through the rest of it. But I wanted to share my definition, which is a little long-winded, but something I've been thinking a lot about. So my definition of health equity is focused attention and effort towards addressing health disparities that are the result of societal forces which drive marginalization of various identities or the intersection of those identities. These efforts can take place on many different scales, including individual, institutional, or societal, and in many different arenas like clinical care, community organizing, legislative advocacy, or research. I think the marginalized identities may be rooted in race, gender, identity, sexuality, ability versus disability, insurance status, immigration status, native language, incarceration status, religion, mental health, past trauma, or other lived experiences. And so as you can see, I mean, this is a fairly broad definition of health equity, but I think part of the reason that I like it is that it acknowledges that everybody does equity-related work in their own different way. And I actually think that, you know, today's academic half day showcases that in some way. You know, Eamon talked about the effects of imperialism on health. Amelia talked about trauma-informed care, and now here I am talking about substance use and how that kind of influences one's health. And so I think that this definition really opens up a lot of space for how we all practice health equity in our own ways. And I think, you know, in my own personal reflection, I've struggled a lot to identify exactly where I fit in the landscape of health equity, given the, you know, identities of privilege that I hold. And in some ways, I feel like my definition of health equity helps to alleviate some of those uncertainties because it helps me frame all the different places that I might end up spending some of my time in the pursuit of health equity. So with that, I think we'll conclude just by talking briefly about, you know, tying this all together and thinking about why is substance use a matter of equity to begin with? Why did this all come together in this presentation? And I think my answer for that is multifactorial. So I would argue that, you know, the people who use drugs in and of themselves, that's kind of a marginalized identity. I think that you know, the war on drugs, the criminalization of drug use, the incarceration of people who are using drugs has really kind of driven this to be a pretty marginalized identity in and of itself. I would say that historically drug use has been stigmatized, and people who have used drugs have been estranged from medical care. And so there's kind of the self-fulfilling prophecy of poor health outcomes in this population, which we should address. I think also it's important to recognize that unfortunately substance use can often come associated with other marginalized identities. For example, there's data to suggest higher prevalence of substance use disorders in individuals who are part of the LGBTQ+ community. There is higher rates of substance use in the unhoused population. There's high rates of substance use with comorbid psychiatric diagnoses, and certainly high rates of substance use on Native American reservations. So I think, you know, taking all this into account is important. And then finally, I think this begs the question, why does the US have such a high rate of substance use disorders? What's going on in this country that's driving this? And I would say, I'd like to quote Stephen Bezrushka, who we heard from last week. And I was surprised that he actually didn't bring this up in his presentation, I think during academic half day, but something he talked about with the health equity pathway is that there's a lot of social pain in this country. And I think that sometimes the treatment for social pain can be substances, unfortunately. And I think when you think about why there's lots of social pain in our country, I think it's like Amelia highlighted and Eamon highlighted in his presentation as well, is that this country unfortunately has deeply ingrained systems of oppression. There's rampant systemic racism, white supremacy, there's ableism, there's sexism, there's, to reference previous presentations, there's a culture of imperialism and a prevalence of trauma, and so I think we as a medical community need to work to address these issues. And, this is the end of my presentation, and I don't mean to leave it on such a bleak note. I think Ryan Abe and the rest of the health equity pathway residents can probably attest that usually I'm a pretty glass half full kind of character. And I think what I'm really trying to highlight here is that there is lots of work to be done here and plenty of opportunities for us all to get involved in kind of advancing health equity and making the care we deliver more equitable to our patients. So I think that's going to wrap it up, and I'm just 1 minute over time. So there are my references. And I'm going to stop my share so I can actually see people's faces now. Joey, thank you for your kind service, my friend. Any thoughts, comments, questions?